Thank you very much, Helen. I did do my pledge, and my daughter wanted me to pledge to be on my phone less. I couldn't quite bring myself to do that. So here's my pledge, which is I pledge to publish more stuff about quality and safety in the BMJ. And I've just done my 5 days and my resources, and I'm going to get together with my colleagues from the BMJ who are here. We've got Kath McDermott, Tessa Richards, Richard Hurley, and others from BMJ generally, discuss what we've learned, come up with some commissioning ideas. We'll be in touch with many of you. I've just met our next speaker. I'm going to ask him to write something for us. And also, I'm going to send you all an email. You'll be delighted to know. Inviting you to submit to the BMJ. We've also got BMJ quality improvement reports for your quality improvement reports to get them published. We've got BMJ Open, and of course we've got BMJ quality and safety in healthcare. So I will be sending you an email. Do send us your thoughts on what you'd like to publish with us. We want to get this message out more widely to the world. So thank you very much to everyone if you'll respond to that. Now, a few announcements before I introduce our two keynote speakers for this morning. First of all, we've got some lunch events today, launch of the new Get Up, Get Better International Healthcare Quality Competition, and also the Harkness Fellowships presented by the Commonwealth Fund. And don't miss the last keynote of the day, which is going to be fantastic, from Simon Berry, what we learned from Coca-Cola, taking cola life to scale in Zambia. A very inspiring story. I know you won't want to miss that. I want to thank our sponsors again, the Health Foundation, Bupa, DNVGL, KPMG, NHS Improving Quality, and the Commonwealth Fund, without whom this meeting would certainly not have been such a success. And before I move to the speakers, just to let you know the Twitter statistics, with great big thanks to Hannah and the rest of the Twitter team and the info DJs who've been in every session. The Twitter stats are 2,500 of you have been tweeting. I mean, I think that's pretty nearly everyone, so that's a fantastic result. Nearly 13,000 tweets across the whole week, reaching an amazing 15.5 million people. So that's fantastic. Give yourselves a round of applause. So now to our two keynotes, and I should say that we're probably going to overrun slightly, so I will keep them to time, but it will mean we'll go over the 10:30 slot, I should expect. So both of the speakers today are talking in various ways about ethics and about the way in which we provide healthcare in a better, more ethical way. And the first speaker is Professor of Immunology and Director of the Centre d'études du Vivant in Paris. He is an expert in programmed cell death and has researched the role of cell death in disease and in evolution. But he is going to speak to us today about ethics and human rights in medicine and public health. I'm very delighted to introduce Claude Ameisen.
And good morning, and thank you for having invited me. One enters into ethics, said the French philosopher Paul Ricoeur, one enters into ethics when, in addition to stating his or her freedom, one states the will that the freedom of others be. I want you to be free, added Ricoeur. And it's a different view from the view that one's freedom ends when the freedom of the other begins. It places freedom as an interactive process, as a collective and individual process, as an interdependent process, and as an emergent process. It also links tightly autonomy, freedom, and solidarity, which are often seen as conflicting because it presents freedom and solidarity as being closely interrelated. It's also a step towards the other and also a step back, because I don't know what your freedom is in your opinion, and you don't know what my freedom is from my point of view. So it means it can only be discovered by listening, by questioning, and by dialogue. And the question is, how do we integrate this view and concept of freedom in healthcare? And first in medicine. And as you know, one of the powers of modern medicine is that it is an evidence-based process. But in evidence-based medicine, evidence is reproducibility, which means statistics and probability. So the best care is given when we can look beyond the singularity, the unicity of the person, and assign the person to a statistical group. And precision medicine, so-called personalized medicine, goes one step beyond by segmenting people through different biological features, for example, in cancer, taking the tumor genome and assigning it to other tumors to find the best treatment, and taking the person's genome and assigning it to other person's genome in order to prevent unwanted side effects. And so the question is, in this context, how can we let emerge the freedom of the person and its singularity? And one of the pillars of modern bioethics is free and informed consent. But free and informed consent, by the way, is not so much about the right to say yes, it's about the right to say no, to be able to say no. And it could have been called a free and informed refusal process, and everybody would have said, why do you presume people will refuse? Why do we presume people will consent? So the real process should not be a yes or a no, but a process where the person can build a choice with the help of the health caregiver, of patient association, of peers, and really elaborate freely a choice. One word may be about economics. Cost-effective healthcare is very important, but I find something strange in the way healthcare costs are usually viewed. As you know, a lot of international bodies like the World Bank and other evaluate the cost of not having an effective healthcare system in countries which lack them. And when you have an effective care system, we evaluate the cost of having an effective system. So it's one of these rare activities where it costs when you don't have it, and it costs when you have it. And so I think there is something to be thought about the cost of healthcare that will allow to put it out of these strange surroundings. Medicine, there is more to healthcare than medicine. Medicine looks into the body for signs of disease or signs predicting disease and treating them, but public health looks at prevention, at primary prevention, and so look at environmental factors, at social factors, at economic factors, cultural factors that may endanger health or that may harm health. And we know that it's a long time that we know that social and economic factors have a high impact on health. 150 years ago, Villermé in France and Chadwick in England showed a very close correlation between poverty, illness, and life expectancy. We know also that catastrophes that will have a toll on health, like the Katrina hurricane, the Haiti earthquake, the heat wave in France, or economic or environmental crisis, have the biggest health toll in society or population where the social conditions, the economic conditions are the poorest. So there is a vulnerability which has a social and economic and cultural texture. We know also that in the absence of any catastrophe, hunger, pollution, unavailability of drinkable water will cause disease in the absence of any particular event. So in addition to access to healthcare, which is essential, living condition can harm health. And so looking at social, economic, and cultural condition is something which is important. But as in medicine, and maybe more because it's public health looks at population, at statistics, at epidemiology, the question is how can the subjectivity, the person as a subject, be integrated in a public health approach? And this this goes back to the definition of health of WHO, which is, as you know, that health is not only the absence of disease, but a state of physical, mental, and social well-being, which has at least two implications. The first is that health cannot be only defined from the outside. Well-being means that the person has to express itself. I cannot know if somebody is well without asking the person how she or he feels. And the other is that social well-being is beyond the scope of classical healthcare or medicine. And which means that if we don't want to medicalize every problem, healthcare and medicine can contribute to the well-being, but cannot alone achieve well-being. Now, how to integrate the person, its subjectivity, in the context of public health, in the context of social environment, economic environment, where the person will be seen as an object of social determinants and not as a subject able to express himself or herself freely. And one of the answers was proposed 17 years ago by Jonathan Mann from the work he was doing on AIDS, saying that human rights, thinking about human rights, is an alternative or complementary way of thinking about socio-economic and cultural determinants. Why? Because human rights address populations, but with a focus on each individual, which means it allows the individual, the person, to re-emerge from statistics or from an anonymous population. And so it's not only that human rights should be considered. What Jonathan Mann tried to show was a little bit like Amartya Sen had showed for famine. Amartya Sen had shown, as you know, that in most instances, famine were not due to the lack of food, but to the uneven access to food, which means people were dying from hunger in a context where enough food was available. And he proposed that human rights consideration, capability, access to right, democracy is the best prevention of hunger independently of the production of food. And what Jonathan Mann proposed is that human rights and the respect of human rights is an important factor of health, because non-respect of human rights, non-respect of dignity can affect health, not only in its essential dimension of well-being, but also in provoking diseases. And that the classical medical view or biomedical language or epidemiological view can sometimes not be able to see the connection between human right denial and disease. He wrote that an exploration of the notion of dignity and of the settings in which dignity is violated could reveal an unknown continent of suffering towards which the classical biomedical language could be inapt to describe and to understand, or, as he said, inept. So it's another way to look at promoting well-being in taking into consideration this interactive freedom concept. Now, this notion of human rights has been integrated in the context of bioethics in medicine and healthcare, as witnessed by the UNESCO Universal Declaration, which is entitled, the declaration which has been made 9 years ago and adopted by every state, which is a Universal Declaration of Bioethics and Human Rights. Article 14 of this declaration says that enjoyment of the best attainable health standard should be considered as one of the fundamental rights of each human being. And the Article 14 adds, independently of social or economic conditions. And so it's a very ambiguous statement, because does it mean that if a person lives in poverty or has no access to a lot of fundamental efforts will be made that his health attains the best standard? Or does it mean that social or economic conditions should be changed in order to attain this kind of standard? So I think that on some level, healthcare, well-being, questions the way we build our societies. And our societies leave an imprint which is profound and non-egalitarian on the health of a lot of people. And we ask, usually, healthcare systems to prevent and repair the damages that our society creates on health by the way it functions. It can be extreme situations, but work since quite a time by Michael Marmot and others, like the Whitehall studies, have shown that subtle factors, subtle social economic factors, can have significant impacts either on illness, on invalidity, or on life expectancy, which means that relationships between people, the way people are taken into account or not, can have long-lasting effects that can be correlated with differences in life expectancy. So it's not only wanting people to be free, but it's listening and allowing people, and mostly people which are in the most vulnerable state, to express themselves and to enter in dialogue. Because exclusion is sometimes, and is very violent, is explicit, but very often exclusion is implicit, which means it's so obvious, so evident that we don't see it. Or when we see it, we think it cannot be changed. It's something that can not be moved. And the philosopher Martin Buber said that the only thing that can be fatal to humanity is to believe in fatality. So I think listening, allowing people, everyone to enter into dialogue comes with the idea that things can be changed, because once again, individual and collective freedom is an emerging process. So maybe there is more, and surely there is more to health than healthcare can achieve, but maybe one of the answers of trying to achieve the best possible health and well-being is just care, which means caring for each other, not in the place of the other, but by allowing the other to express, to enter into a dialogue, to be empowered, to gain capability, and to build together a well-being which cannot be seen, if we take Ricoeur's view, which cannot be seen as an solely individual goal, but that a goal that can be achieved only if it's collective and if it involves everyone. Thank you very much.